Thank you all for your patience. As always, when there's technology, there's opportunity, and we just had an opportunity. Dr. Jones, the panelists are all convened with us this afternoon. On the screen, you'll be able to see each of them as they ask their questions. Your questions were forwarded to Dr. Jones, but I don't know that she over-prepared. I think she'll be more spontaneous, and we do appreciate that. So we do have 8 panelists, and we do have over 100 participants that you do not see, but they are active and encouraged to participate in the chat. I will be watching the chat and offering any follow-up questions or end of session questions. So really the audience can participate as well, but we do need to be mindful of the time. I will share with you though, that although Dr. Jones originally scheduled for 30 minutes, sort of behind the scenes, she secretly let me know that she's willing to go a little extra. She certainly wants the students here and the faculty staff at the college to be able to interact with her. So everyone has met Dr. Jones. Let's go ahead and get started. I'll introduce each of the panelists and then you can move forward with your question. We'll begin with student Dr. Dozier. She represents her community, which is the Blue or Trinity. Dr. Dozier.
Hi there, my name is student Dr. Dozier. I'm a first year osteopathic student, and my group wanted to ask you, it's kind of a long-winded question, but I've provided a little background just to put some context behind the question. So accessibility, equity of care, and stereotypical misconceptions or assumptions are a continuing problem in healthcare. Because of these problems, some patients may be hesitant to reveal certain qualities of their lives, like social determinants of health, which may impact diagnosis and treatment. What are some common misconceptions that may negatively impact the healthcare of patients of color? For example, higher pain tolerance in African Americans or exaggerations in Latino Americans. And how can we incorporate those social determinants that patients may conceal while also trying to achieve equity of care in a system that was not designed with this as an end goal?
So when I did read the questions beforehand, oh, I'm back. Okay. I did read the questions and I thought that that was an amazing question. My first reaction is that we shouldn't be seeing our patients in categories. And so the first advice I have is that, because anywhere, if now we're not on planes, we're not on buses, we're not on trains, so much, because we're kind of hiding from the virus. But when we were sitting on park benches next to each other, you could just turn to anybody and within 2 minutes talk to them and find something that you all had in common. I encourage us as healthcare providers to do the same with our patients. When you first meet a patient, don't just go in there and look at them and say, well, it doesn't remind me of my son or my daughter, doesn't remind me of my mother or father or my sister or brother or husband or wife, so therefore I don't think there's anything in common, but to actually engage and find out what you have in common so that you can engage in a human way with a sense of respect. So that's the first thing. So then you won't be, it's dangerous when we teach, the whole thing of cultural competence at the beginning was, that people could be competent in other people's cultures, but people are not. People have culture, all of us have culture. People now talk about cultural humility. People now talk about structural competence. Those are very important approaches. But in the end, if you're going to engage with your patient, you need to find about their individual histories, their individual desires, their individual gifts and talents and connections and all, and then you start from there. Don't make assumptions. And I would also say that thing of engaging with your patient will slow you down. It will start taking away the, like the implicit bias assumptions about different groups or that. I mean, you'll see them as a human being, which is what we all are. So that's the first thing. So that's from the physician side. From the patient side, in terms of hesitance, well, if I feel seen and honored and valued and appreciated by my provider, then I won't be hesitant to bring up real things. The system part of it is also having the time to get the important issues from the patient, and encouraging for the next visit for the patient to just keep a little list of questions that arise that they want to bring up with you next time, which then shows that you want to hear from them. And even though the things they might bring might be all clinical, but then, and then to inquire, how are things, certain questions, how are things at home? Do you have everything that you need to take care of yourself in the way I'm recommending? What's getting in the way? So in a respectful, really inquisitive way to engage with the person as another person. So I guess that's it. To recognize the humanity of that patient.
Thank you.
I'm not seeing any follow-up in the chat, so let's move on. Dr. Lee?
All right. Dr. Jones, thank you for your wonderful talk, coming to speak with us here at the College of Osteopathic Medicine. I'm Tucker Lee. I'm a family medicine and sports medicine physician, assistant professor of family medicine here at the COM. And speaking as part of the research committee, one of the questions that we had for you today was in the form of a curricular question: how can we best incorporate anti-racism principles into our undergraduate medical curriculum in order to equip future physicians for the challenges of serving rural and underserved communities?
So the first thing is to be unafraid to say the word racism and to describe your efforts as being about anti-racism. I also need to say that that definition I gave of racism can be generalized to be a definition of any system of structured inequity. So for example, what is sexism? Well, that's a system of structuring opportunity and assigning value based on gender that unfairly disadvantages some individuals and communities, unfairly advantages other individuals and communities, and saps the strength of the whole society through the waste of human resources. And when I have more time, I often, I have 3 or 4 slides that go through this. There are many axes of inequity operating in our society today, intersecting in communities and in individuals. So they include, immigration status, language, urban, rural stuff, social class markers, body weight in some instances, so there's a whole religion, gender, so-called ethnicity, so-called race, and all of these things. And so I acknowledge that all of these go on. And sometimes people are surprised. Well, Dr. Jones, you talk so much about race as the axis of inequity and racism as the system. And now you're admitting you recognize all of these other systems of structured inequity. What's up with that? And my response is that, yes, I recognize all of this stuff is going on. And I think we need to be engaging in as many of these struggles as we can. But that actually, I think that all of us need to be actively anti-racist, because racism is foundational in our nation's history. And yet so many people are in staunch denial of its continued existence, much less its profoundly negative impacts on the health and well-being of the nation. So I encourage all of us to be actively anti-racist, even as we engage in the other struggles. And to the extent that we're able to identify and dismantle the systems, the structures, policies, practices, norms, and values of racism, the other isms will be benefited, addressed as well. So there was a 2-part thing in that. The first part is that, yes, I encourage all of us to be actively anti-racist. Yes. And that will help us in addressing rural, poor, all of that. And it's connected. So it's not even an either or, as I was saying before. And I don't know, so in rural parts of Southwest Georgia, people sometimes in the nation think rural means white, right? But in Georgia, it means Black. In Texas, it might mean Hispanic or Latinx. So, so I don't know what it means. But so even these terms, and we start thinking we're talking about one thing and another. But being so then how do you, okay, so the first is to say the word racism, right? And to be about being anti-racism. I don't even say anti-racist, because when you say anti-racist, people think you're talking about a person. I'm talking about a system. So to be anti-racism. And then to the 3 principles that I just quickly went over, because I went over everything very quickly, but the 3 principles for achieving health equity will be about achieving health equity with regard to to all of these systems of structure and equity. They are valuing all individuals and populations equally, recognizing and rectifying historical injustices, and providing resources according to need. So you could present that in the curriculum as this is what we are about, that operationalizing this in different contexts and all, but this is what we're about. Think about, how do you value anything? You protect, you cherish, you invest in, you invite the voice, you celebrate. I mean, we could make 100 words that mean value among the group that's on here. So valuing all individuals and communities, how are we going to manifest that as an institution, and even in our teaching? How are we going to manifest that in terms of in terms of like rejecting these ideas of biological determinism, for example, that student Dr. Dozier was referring to before, you know? So those kinds of things. So the second, recognizing and rectifying historical injustices, requires, what is our history as an institution? This is easy because this is a very young institution, but like why are we even here? Like, why are we here? What is the history of this location? And why are we in this location? What is the history now of this state? What is the history of the US? What is the history of the various people who are part of our community? So recognizing and rectifying historical injustices, because when you're looking at some of the, why is there an urban-rural economic divide? Why is there an urban-rural broadband divide? Why is there an urban-rural kind of, access to highways or whatever, why is it? Doesn't have to be that way. So you have to examine why are we not investing, for example, in rural areas in the ways that we might, and what can we do? So recognizing and rectifying historical injustices, and then providing resources according to need, which has 2 steps to it. The first is to establish a metric of need on which everybody agrees. So might that be infant mortality rates? Might that be the death rates from COVID-19 per 100,000? Whatever that is it broadband or not? Is it whatever the metric of need? And then when you get resources, it still requires political spine to distribute those resources according to need, according to that metric that you all agreed on. Because I can imagine a state health officer with 5 counties in the state gets $1 million. The reflex is to give each county $200,000. But this political spine thing might be to say to County A, you won't get any this year because County E needs that. And in fact, you may not get any the next year or the year after that. And the hard part about that is people do not compare themselves to those who have less than they do. They're always comparing themselves to those who have more. And so people are always feeling, well, I need. The people on the cliff, the oranges are never looking toward the edge of the cliff at the greenies and worrying about them. They're looking at the others, the yellowies that are further away, right? So this is a problem too, which is about the bubble bursting and understanding. So anyway, I've just gone through a whole bunch of stuff, and I know it was supposed to be a quick answer. But anyway, that's my response.
Wonderful. Thank you very much. Appreciate it.
Dr. Jones, you just empowered this group to use that word, racism, and to begin to grapple with individual understanding as a first step to combating. Thank you. That was very powerful.
Okay.
All right, let's move to the next question. Student Dr. Mathew.
Thank you, Dr. Hopper, and thank you, Dr. Jones, for giving us this talk today. We are really excited to have you. I am Arwen Meador. I'm a first-year medical student at Sam Houston State University, College of Osteopathic Medicine. Our group had this question for you. In your TED Talk, Allegories on Race and Racism, you compared viewing racism as moving through life on a horizontal escalator, where some people are passive and others are taking an active role against fighting racism. As future doctors that are hoping to take an active role in being anti-racist, how can we encourage and motivate our colleagues to not be passive about racism and fight against structural racism with us? Or in other words, how can we influence others to not be passive?
So the first thing is that many of your colleagues might think that racism doesn't exist. So the first thing is to, you could do the storytelling thing that I do with, the open close sign, or you could even have people read history. So I think that for people to understand, as I went so quickly through the 7 values targets, we're so ahistorical. People don't really understand how things came to be a certain way. And they might think in the myth of meritocracy, actually there are four of those 7 things they underlie racism denial in this country. So if you are narrowly focused on the individual, then systems and structures are invisible or seemingly irrelevant. So racism, what racism, right? Like what system? Then if you're ahistorical, then you think, what are we trying to explain? Or, that was my great grandparents. It wasn't me. I didn't do anything. Let's start with a new fresh slate, right? So, so that underlies racism denial, that it has nothing to do with it, and then when you add in the myth of meritocracy, well, pull yourself up by your bootstraps. I earned this, I did this all on my own, which none of us does, but, people not recognizing, I didn't say this before, but, when people do understand that there might be 2 states of being disadvantaged, but they never put the other one as advantage. They say disadvantaged and normal. And the reason that people think that there are 2 states of being disadvantaged and normal is that we're ahistorical, and people don't understand that their so-called normal is built up on a whole mountain of unfair advantage. So those 3 things, and then white supremacist ideology, which has in that biological determinism and all these ideas, but this false idea of a hierarchy of not only of human body form or whatever, but of human valuation. So those things are about racism. They are the undergirdings of racism denial in this nation. And so the first message, I gave 4 key messages. The first is to let your colleagues know racism exists. And to let them know that, then they need to maybe do some of the bubble bursting. They need to read the history. They need to understand more. So I don't think you can convince them on your own that racism exists unless they follow their classmates of color or listen carefully and believe the stories of their classmates of color. That might help convince them, or unless they do the bubble bursting and spend some time, not in a voyeuristic way, one time across the tracks or whatever, but get to know people and then actually understand that what they may have considered to be lucky was actually an expression of white privilege, because somebody else had the same situation, but it didn't turn out exactly the same way for them. So there are lots of things. So that first, racism exists, may be the biggest hurdle. Then the second thing, that racism is a system. And so that even though there's personally mediated racism and it can cause bad actions, bad ideas and bad actions, that really the core is a system. And I have a new allegory, but I'm not going to spend the answer time to your question. At the end, after I've answered everybody's questions, I want to, if we have time, tell a new allegory that helps illustrate that. The third one being that racism saps the strength of the whole society. That might be where you start getting their interest, especially if they tend to be motivated by self-interest, which many people are. And then the fourth is that we can act to dismantle racism. So then in your own example, ask questions. Why did you say this? What did you mean by that? Well, I observed that we, treated patient in the room such and such a completely different way than we just treated the patient in this room. Why is that? I do not understand this, whatever. So you don't even have to call out people and say, well, you just did something that I perceive to be racist. You ask questions and all. But to get your colleagues along, you have to help them understand that this is not you picking an issue for 2 years, that you are observing our society and deciding that you don't want to continue to participate in that same way. I hope that was helpful.
Yes, it was. Thank you so much.
We are starting to get a few follow-up questions, Dr. Jones, but I think we'll hold them to the end and we can circle back to them.
Sure.
At this time, Mrs. Johnson.
Hello. Hi, I'm Tess Johnson. I'm Director of Medical Student Affairs here at the College of Osteopathic Medicine, and I serve on the Diversity, Equity, and Inclusion Committee. So the question I will be asking is on behalf of them. And I would like to say that this has been very impactful for me, and you have really poured into me today. So thank you so much.
You're welcome.
So food deserts are common in disadvantaged neighborhoods. They force residents of those neighborhoods to make unhealthy nutritional choices. What can be done to solve this problem? For example, can a commissary-like system be set up via the U.S. Public Health Service to relieve food desert conditions in disadvantaged neighborhoods?
I found that when I read it to be such an interesting question, because I've had similar ideas. I want to put a framing, and then I want to say the idea is interesting, but I wouldn't, Well, I'll start with that I wouldn't make it a U.S. Public Health Service commissary. I would equip the residents of that community, you know, to farm and then learn about food preparation and do a co-op. Because I have for a long time thought about, you know, when I went to college, I could just go to a cafeteria and eat, right? And choose a few things, and hopefully they were healthy. And then I could sit and other people in my community, we could sit and we could talk or whatever. I thought, what if we had a cooperative community cafeteria like that, where the food might be grown locally by people in the community, and, you know, then you would train people how to cook and how to cook healthily, and it would be a co-op, so, you know, people could, and if you couldn't do it because you had some other job, then you could pay into it, but maybe it would even be cooperative in terms of work and employing people and people getting better knowledge. But then, and maybe it's open, at least maybe it's open from 2:30 in the afternoon to 8:30 at night. And so kids maybe coming, this was when kids were in school, like I don't know what you guys are doing in Texas right now, but in the community, that people could go, they could get a healthy food, and they could also have a place, a safe place to talk or whatever, maybe some homework stuff or after school stuff, but also community members, instead of going and being isolated in their homes and maybe eating as families, could start talking to each other about what's going on in the community. What can we do? What ideas, you know, do you have? What do you know about in terms of other work, or what, you know, it could be a community space that was hiring people. It was using community grown produce. It was giving jobs and skills. It was giving nutritious food, all of these things in a cooperative way. So when I saw that idea, yeah, the food part is nice. But that gets to the other piece. People focus on behavior, like, and it matters what people put in their mouths, right? So that's the first thing, you know, and some people put less healthy foods in their mouths than other people, but then, so we have to go beyond the individual and the individual behavior to ask why. That's what you guys have talked about. So we need to talk about the social determinants of health, and maybe healthy foods aren't even available in your context. So these social determinants of health are the context. But the next why question is why we get to racism and anti-racism, because it doesn't just so happen that some people find themselves in certain contexts and other people find themselves over-concentrated in other contexts. So when you ask, why do we see the range of contexts that we see in our society, in this state, in this city, and why do we see the disproportionate placement of different populations into those contexts? You're going beyond individual, yes, to the social determinants of health, but then you had to go beyond the social determinants of health to say, well, these social determinants of equity or inequity, you know, the racism, sexism, and all, because those are the systems of power that decide. The context might be, do you have a farmer's market? The social determinants of equity decide who is at the table deciding whether or not you are going to have a farmer's market there, or whether or not a farmer's market is what you really needed. So the one thing is the context, the program. The other is who's at the decision-making table deciding what the program is going to be. And that's why the importance, that's how you make the whole link. You have to go beyond the commissary thing. Who's deciding what we're going to do and how we're going to do it? That's the important thing. So you have to involve the community members in creating the solution and then being part of the solution, not just advising or giving consent after a solution has been presented.
Well, you've thought about that before, obviously, and maybe have empowered some people here with some ideas for community engagement within our local community. Thank you, Dr. Jones. Let's move to the next question. Student Dr. Ram.
Hi, good afternoon. First of all, thank you for being here with us today. It was a great YouTube event, and we're very excited to have you here as well. My name is student Dr. Ram. I'm a first-year DO student here at Sam Houston, and I'm representing the Yellow or Guadalupe learning community today. Especially with everything going on in today's society with like Black Lives Matter movement and all the protests and everything. Everyone in like the younger generations are becoming more aware of the racial biases we may have experienced or grown up with. So our question was, what tools can we use to prevent racial bias in medical students? And how do we overcome any of those biases, implicit or otherwise, that students may already have before entering medical schools?
So it's going to take, so you can't fix somebody else, right? So it's not about fixing. So I think it's going to be an awareness, raising awareness, raising that racism exists, all of those things, right? And then, people have done the implicit association test, which you can do on the computer to see, do you kind of subconsciously, implicitly associate words that are good or powerful or smart with whiteness, for example, and that are bad or weak or, not intelligent with blackness. And you can do it across, all kinds of things, race, ethnicity, gender, So this implicit association test, I don't know if you guys are into that or have used it. It was developed by folks at Harvard. People have different experiences with it. I think that it's interesting, not so much. So the first thing is, if you do the IAT, you will get a score. And if you repeat it 2 months later, you'll probably get about the same score. So it's a pretty stable measure. Some people have tried to then see, well, how could we train people to alter their implicit association test scores, their IAT scores? And those scores have proven to be a little bit resistant to change. But I've heard people who are psychologists talk about, when you know that you have this implicit bias, what you need to do is slow down so that you're not acting on implicit bias, but that you're actually acting on things that are at the conscious level. So they say police officers, for example, when they're under stress, they have they're more likely to move fast and act on implicit bias. But if there's just something that slows them down, then they would be less use of the gun, or fatal interventions and the like. So that's an interesting thing too. So, and the implicit association test scores, when you look at them over a population, so let's say compare Texas to Georgia to Hawaii, the population distribution of those scores is apparently, I haven't read at these data, so I'm talking about things I heard now, right? And then you guys can go and try to find the studies. Associated with levels of, let's say, police killings or infant mortality rates or whatever, so that it's capturing something at the kind of, as a racial climate measure. It's capturing something at the individual level, but the most important thing might be, how do we make interventions, not at the individual level, but at the kind of aggregate level? So how can we change policies? How can we change media communications and whatever to change the IAT scores, not individual by individual, but as a cultural piece? So I've said a lot of different things there, but I think that that we shouldn't be trying to fix each other, but educate each other and educate ourselves. I would say that if part of the medical school curriculum were history, medical history, like when you're doing OBGYN, instead of celebrating whatever the man's name is, Samuel Cartwright, is it? Who did which one was the great OBGYN person? I can't remember which one was which. Samuel Cartwright might have been, drapetomania, and a special disease for, that only afflicted Black folks. And it was the insane desire to run away. So there are a lot of these people, but to learn about even race and racism in medicine. So before you teach procedures, learn that those procedures were practiced and perfected on Black enslaved women without anesthesia. So to understand something about that, or to understand that the cardiologist at Johns Hopkins, it was the Black assistant who was always in his surgeries who helped him with the first, whichever cardiac procedure that was. I'm sorry, my mind can't keep all of the details of this, but he was never allowed to go to medical school, but he was the one who actually developed and was credited by the surgeon himself with developing those techniques. So to learn that, so Harriet Washington's book, Medical Apartheid, or Linda Clayton and Michael Bird's, it's a 2-part series, Race in US Medicine, something like that. It's a 2-part series, but it's Linda Clayton and Michael Bird, B-Y-R-D, I think. So the medical history, so maybe you guys could have a course on that. you know, it's like to go deep. And don't be ahistorical. Maybe it's getting back to the three things: value all individuals and populations equally, recognize and rectify historical injustices, and provide resources according to need. Maybe it's that. I feel a little like I didn't exactly answer your question. Is there a follow-up, or is it all good?
Oh, no, it's good. We knew that it wasn't going to be like we can fix everything ourselves kind of thing. Like it's going to be a process. We just wanted to know like your viewpoint on like what you thought that we ourselves could do.
I think that it should be that the medical students should be involved in all of this stuff too, and shouldn't be recipients of. Because first of all, you learn more when you're trying to teach it to others. And so maybe you can join. It shouldn't be on the medical students to do that course development for the faculty. It can be a joint thing, but I know that in many institutions, the medical students who have found that there hasn't been the appropriate curriculum have developed pre-courses for incoming students that they offer themselves. So, and in doing that, they actually, it's three things. So you learn more when you're trying to develop it to teach with others. It's engaging in action, so then you get more involved and maybe even more activated in an activist way. I'm like you become more engaged, and now you see, oh, I can do something. Like I have a thought and then I acted on it, and I can take that action. So then you become more of an activist in life, and more powerful, understanding your power. That's an important thing. Each of us needs to understand our power. Yeah, Dr. Hopper, now I'm just like, woo, all over the place. Go ahead.
So Dr. Jones, we want to thank you for mentioning those references too. I think those will be valuable for our students, faculty, and staff here. And oddly enough, the next person who's up with the question is our medical librarian. She might be able to help us find some of those resources. So I'll pass this on to Ms. Meador.
Hi, Dr. Jones. It's nice to meet you, and I want to thank you for sharing your time and expertise with us this afternoon. I will be asking a question on behalf of the research committee. And our question is as follows. Data about infection rates, hospitalizations, and mortality from COVID-19 reveal worse outcomes for African Americans and Latinos. Understanding that we must strike at the root of the problem, structural racism, and recognizing this work takes time, how can we address these current critical health disparities in a meaningful way?
So it's certainly not by saying, it is what it is. So my analysis of what's happening with COVID-19 is that, and the disproportionate impact on communities of color it's two buckets of things happening. First, we're more likely to be infected because we're more exposed and less protected. And then once infected, we're more likely to die because we're more burdened by chronic diseases with less access to healthcare. So each of those four things, more exposed, less protected, more burdened by chronic diseases with less access to healthcare, is very much wound up with racism. And some of the things are faster to address, and some of them take more of a structural approach. But clearly the fact that we're more exposed, now there are a lot of ways to address that. We're more exposed because we're more in the frontline jobs that are now considered essential. And in fact, meat packing, and like, are meat packing plants really an essential thing? But with the president's executive order saying that meat packing was an essential service and all, which actually just served to protect the owners of meat packing plants from liability when their employees got sick or died. But anyway, so we're more exposed in that way. We're more exposed in terms of being more likely to be unhoused, or more exposed in terms of being overrepresented in prisons, or jails, or detention centers. We're more exposed on public transportation if we don't own a car. We're more exposed in more crowded housing and more intergenerational housing because of residential segregation coupled with disinvestment, right? And all of those things. So we can do something about some of those causes for being more exposed. So we could pay more people to stay safely shelter in place at home. I'm working from home. I've been working from home for months. We could pay more people to do that with a universal basic income, or by resuming the $600 per week unemployment insurance bonus, add-on from the federal government. We could ask the president to invoke the Defense Production Act for the production of masks and PPE, so that even though we might be really essential, that we wouldn't continue to be less protected. We could think about decarceration and continue to have decarceration so that the COVID-19 that runs through our prisons and jails, doesn't run through a captive population. And some of that's been doing. I haven't kept up to how effective that's been and how much more of that is happening. I know that some white collar crime criminals have been let out, but I don't know how many, how it's gotten across the different classifications of people. Like, did everybody who only had 8 months left in their sentence get released home? I don't know about that. But so we can think about things that we can do right now on the more exposed. On the less protected, I already said one thing, which is the production of more masks and PPE by invoking the Defense Production Act. We could give people more paid sick leave or family and medical leave. We could actually, if people had more hazard pay, then they might not feel, they would have more of a cushion when they actually got sick, God forbid, to not feel like they have to go back into the workplace or else they'll lose their job or their family will lose their house. We could actually have more of the mortgage forgiveness or rent forgiveness, but pay not to damage the landlords, but the government to support the landlords and the renters. Germany, Denmark, the UK, New Zealand, there are all kinds of countries that are doing these things so that people will not be as exposed. We in this country tend to be saying it's the economy in some kind of way, not even the real economy on the ground often, but the economy versus health and lives. And I think we've picked the wrong thing. So, and then in terms of how we do the testing, I'll just say one more thing. I mean, there's so many things. Well, the Occupational Safety and Health Administration, it's a part of CDC. I understand they have not yet issued one COVID-19 workplace standard, right? This is what they're supposed to do. So we could call for that to happen, but CDC and all of public health has been muzzled with our handling of this pandemic. I was going to say something, I guess, about the testing, but I'm tired on this. I'm tired right now. Let me drink my water. Maybe I'll be able to, hold on. So I think it's having, I'll say this last thing. Our strategy in this country reflects the fact that we are treating this pandemic as if it were a medical care problem as opposed to a public health problem. We're dealing with it at a very individual level as opposed to a population level. I first understood that with testing, when we were treating the test as if it were just to confirm a diagnosis in people that we already suspected. So at first you were restricted to, you had to be in the hospital, like almost getting on a ventilator, and then they would test you to confirm that was COVID-19 versus some other pneumonia or whatever. Now we're testing symptomatic people and people who are exposed and maybe some curious people, but we still are doing this in a way to confirm diagnosis and document the course of the pandemic, as opposed to actually understanding the fullness of the pandemic in the community with a surveillance approach to testing. What do I mean by that? So as a public health person, we could draw random samples of people every week, and we could understand how much virus is there in this community right now. When we go for positive tests of symptomatic people, we're already 10 days late. Like the picture we're getting is what happened 10 days ago. When we look at hospitalizations, that's a 2 to 3 week ago prevalence of the virus. When we look at deaths, that's what the virus was doing 4 weeks ago. And that's too old of a picture, especially in the context of exponential spread, which is our context in this country. If we are not having people stay at home, social distancing, uniform, mask wearing, hand washing, all of those things. So that was testing. Then I noticed it in how we were thinking about reopening the schools, where the question was, well, the kids don't really seem like they're getting that sick. The question is not whether the kids as individuals will get sick. Again, it's not the narrow focus on the individual medical thing. This is a public health thing where the kids are vectors. The third time I noticed it was when we have all of this emphasis on therapeutics, the development of therapeutics and vaccines, as if that's going to get us out of this, when we have things that we know can control this right now. which are stay-at-home orders, social distancing, mask wearing, washing hands, all of that. But we're so narrowly focused on the individual. And the fourth is how we even think about mask wearing. Where we think about mask wearing, well, if it's to protect me, I'm going to take my chances. But the thing about the mask is not about you as an individual, it's about the community. And the mask wearing, yes, it might protect you a little bit, but it's more about protecting the community from you. Have you guys seen the cartoon about people peeing? Have you guys seen this cartoon? Okay, peeing in pants. I don't want to be crude, but it's about peeing in pants. So you have two people peeing. I mean, two people standing now. If this man has no pants on and he pees, then, and you have no pants on, you're going to get wet. If he pees, no pants, and you have pants on, you won't get as bad. But if he pees and he's wearing pants on, it's not going to get to you, right? The mask is not for him. I mean, you know, so if I'm wearing the pants, it's not to protect me when I'm spewing stuff. It's to protect the other people. So even our idea about mask wearing, I don't even remember what the question was. Oh, it's what can we do about the disproportionate impact? Well, we can do that. We can learn. The short answer is let's look at what other people are doing. Let's look at surveillance testing, isolation of positives, contact tracing, quarantining of those who are contacts, stay-at-home orders, you know, paying people to stay home safely so the economy doesn't crumble. All of these other things that we can learn from so many other nations. When we control the pandemic, we will also be controlling the disproportionate impact on people of color. We are still in the front line, so-called, because of residential segregation and, you know, poor schools, poorly funded schools with poor outcomes, and then occupational segregation. We got that right now, but to the extent we control the pandemic, we control all deaths, which is going to control our excess deaths.
Thank
You
you
see,
very much.
I am talking longer and longer. You guys have to tell me to shut up now, okay? But anyway, I'm sorry.
No, Dr. Jones, you come through that screen with such enthusiasm and passion. How can we quiet that voice? We would not ever want to do that. Really appreciate your thoughtful consideration of the questions. We do have a couple more that are prepared, and then we'll get to a few of the optionals. I'm not sure that time will allow all of them. Let's go ahead and move on to student Dr. Rasheed.
Hello, Dr. Jones. My name is Amir Rasheed. I'm a first-year medical student here at the COM. First, I'd like to thank you so much for the incredible talk you gave on racism. I think it's really important for us to now really encourage those conversations within our own communities to kind of make a greater impact. So the question I have for you from the Green Learning community is, based on your experiences working on social inequalities in healthcare, what are some current initiatives being implemented to eliminate disparities among different races in underserved regions? And what are some of the associated challenges, specifically in the context of receiving preventative care on diabetes and congestive heart failure, two chronic diseases that are very prevalent in our service area here at the COM?
So I think that I will say that I do not have the exact answers to you, but I will tell you about the approaches and give you hospital systems where you can look for the exact answers. There are hospital systems that are recognizing that health is not created within the health sector, and also recognizing that they as hospital systems have roles in the community besides just providing excellent care to those who present to the door. So there is, the Democracy Collaborative has a network called the Healthcare, it's probably Healthcare Anchor Network, might even be Hospital Anchor Network, HAN, but look at Democracy Collaborative. So they include Rush Hospital System in Chicago, or the Boston Medical Center in Boston. I think there are about 37 of them in this Healthcare Anchor Network is probably what it is. And they are recognizing their roles as people who hire folks, so employment, or investing in neighborhoods, or, you know, procuring services, even as a platform. I was at Rush once to do a talk, and it turned out that every Thursday in the cafeteria, they open up the space to local vendors. So what they're doing is not trying to solve a health problem with specific health protocols, which is also an important part, but they're recognizing that they are an anchor network in their communities and that health is not created within the health sector. And to the extent that they can improve incomes, increase employment, be a pipeline for the young people, to come in and do jobs in the hospital, but then, be inspired to be physicians and the like. So I would say that's one model. Community-oriented primary care is an old practice model where a health institution takes responsibility for the health and well-being of a geographically defined community. Again, and it's done in partnership with people in the community. And it's not just to address the need that presents at the door, but to address unrecognized, even unmet need. There's a lot of community conversations. It often involves the hiring, training, and deployment of community health workers. So that's another very old model. But if you Google community-oriented primary care, you can learn something about that. People have noted that patient-centered medical homes is not COPC, but if it were community-centered health homes, that might be getting to COPC. And then I guess the last thing is for hospital systems to be fearless in examining their own data. Their data by maybe by unit, by provider, by whatever, to see is stuff differential going on right now by race, ethnicity, so that they can examine their practices and then to identify best practices that they need to implement throughout. So that's just like three quick ideas about that.
So student Dr. Rasheed, thank you for that question. And I'm very anxious to have a look at some of the documents that Dr. Jones referred us to. Be great conversation for us here. You point out two really important conditions in our rural areas that we hope to serve. So great question there. We do have one more question that's been prepared, and this will come from Dr. Wooten.
Hello, Dr. Jones. This is Dr. Wooten. I'm an assistant professor of pathology at the College of Osteopathic Medicine here. And it's been a pleasure to listen to your talk and thank you for coming and giving us all of these great things and interesting things to think about. My question is, you talked about the difficulty for those that are inside privilege to recognize that they are actually privileged. So what advice can you give to our student doctors to help guide them in their learning to be mindful of their privilege in order to be understanding physicians of every patient that they will see?
Right. So I would say, so exposure in communities. And I don't know if you guys, right now here we are in COVID land when you guys started, so it's hard. But different medical schools involve their students in a community health course, for example, for a year, where they might be every week in the same community. At Morehouse School of Medicine, I'm going to describe our community health course, 1-year course, starting as soon as people get there, or maybe 4 weeks after, because they do some stuff in the summer, but starting with the fall semester. And a few lectures, before you meet your community folks, but you're in a community site where the preceptors have been there year after year after year. And you first try to do a community assessment, but you're working in the site, and part of it is doing service, and then part of it is service learning model. So the service, and then the learning part is doing an assessment of the community issues and stuff, and then presenting back to the community what you heard, and then trying to get from the community what they would like you to work on in the second semester. And so then doing some kind of project and then evaluating it in partnership with the community. What we see when we have our students do this in these different communities, which are mostly not like the communities that they grew up in, they go in timid at first. And they're like, like they don't know how to talk to people, and they don't, And then by the end, they're calling up, the director of the Boys and Girls Club, or, when you said that, they get engaged. It's a bubble bursting activity, but it also helps them understand that there are real people who live in very different circumstances who are just like them, right? But didn't have necessarily all of the opportunities. So it's a long-term bubble bursting in an educational context that can help people understand that the people who are living, you know, in the so-called projects or whatever, you know, are just like them and as smart as them and are trying to solve their own problems. And that instead of treating them like they're some different kind of person, you know, you understand. And now you've broadened your idea of what humanity is to include people like that. And therefore, when you have patients like that, you can respect them and treat them with their full humanity. And the other thing I want to say is reading. So I started giving you some books, but here's some of the books that I just rattle off when I think people should read stuff. I think they should read The Color of Law by Richard Rothstein, which describes how the federal government was involved in forcibly maintaining racial segregation in cities and in housing. I think people should read Just Mercy by Brian Stevenson, or The New Jim Crow by Michelle Alexander. I think people should read, I haven't read this yet, but William Darity, and another person just wrote a book, From Here to Equality, which is about, he's an economist at Duke, about the case for reparations. But we could read Randall Robinson's book, The Debt, from a few decades ago, which is the case for reparations. We should read Isabel, oh my gosh, The Warmth of Other Suns. Tell me. Cast. She wrote both of them. Isabel Wilkerson, The Warmth of Other Suns, and her new book, Isabel Wilkerson, Cast. And then there's, you know, so if people start reading, not just like the straight up history, they need to read a history book too, but to contextualize what we see right now in a historical context, so they can understand that people have not chosen to be in certain situations that are not as healthy. They haven't chosen the conditions that are giving them the diabetes, that this thing happened to people who are just like me, right? And when they can get that context, then maybe they will be better physicians. The other thing I would warn against is social determinants of health screens in electronic health records. That's all well and good, but to what extent does that that goes to the first question from student Dr. Dozier. Like, how does that keep people from really engaging and asking the question at the provider level? And I really think the best thing for physicians at whatever level is to maybe do home visits again, or to be active as, you know, on the school board in a community, or in some other way, to use the power that comes from your role to be in communities where your patients come from, to be helping and to get to know that community. Then there is not going to be so much error in translation, right? Because you'll have experienced it.
Thank you.
So Dr. Jones, that is the end of our prepared questions. I will say I wish so much that you could be here with us personally to, you know, I think we all long for that time of togetherness, and also that energy that I could feel you exuding, but it would connect a little better, I think, in person. But I also wish that you were here so you could decide which of the follow-up questions to entertain today. We do have a number of them, and I don't know if you want me to set another time limit and just offer these randomly.
This is what I would say, is I would say often, like when I was speaking in person and there might be 8 people at the mic and there's only 2 minutes left, I would ask to hear all of the questions. And because sometimes the questions are more important than the answers. So I would like to hear all of the questions, and then to the extent that it might spark me to say 1 or 2 things, I'll say those 1 or 2 things after having heard all the questions.
Okay, can you see the chat? There is actually 2.
I don't want to see the chat. I could, but I'm tired. I'm so sorry.
Okay, well, I think that probably gives us reason to go ahead and pause.
I'll look at the chat. I'll look at it. Okay. So you want me to read the, what should I do with the chat?
So you said you wanted to see the questions?
Here they are, okay. I'm only seeing, oh, should I look at the Q&A? Is that where the questions are?
Yes.
Yes, okay, so I was looking at the chat.
There were a couple entered in the chat. I'd be happy to read those as well to you. Actually, there are several at this point. So we have questions coming in 2 formats, and I have a total of about 10 or 11 questions. I'll pitch the first question, and we'll go from there. We'll just see.
I'm not going to answer them. I'm just going to listen to them. So maybe if you don't mind just reading all of them, that would be lovely. And then
Sure.
they'll be read into the record.
Great. So from student Dr. Grant, growing up in an extremely rural area in West Texas, I personally saw how racism, sexism, homophobia, and bigotry on a daily basis. As a cis, straight, white male osteopathic medical student, I have easily benefited from and continue to benefit from societal and white privilege. As part of the group of people that benefit from these privileges, how can we use this societal structure and these specific privileges to break down racism, sexism, homophobia, transphobia, and bigotry in healthcare to improve positive outcomes for our future patients? Other questions include, I've heard about how medicine as a whole encourages providers to see more patients and often means spending less time with these patients. If this is true, and this is what is expected of the future of medicine, is it possible for a provider who, for instance, works for a hospital and faces pressure from upper management to make a patient feel human given time constraints? If so, how? Next question. How would you recommend, and I apologize, that came from student Dr. Owalabi. Next question from student Dr. Stokel. How would you recommend to discuss racism with the patient that you believe is openly racist, such as a patient that openly uses swastika or other neo-Nazi symbolism? Also, how would you recommend discussing differences in care if you notice it by a superior, such as an attending? Next question by one of our faculty, Dr. Alvarez. Dr. Jones, what a pleasure. Previous evidence indicates health perception is biased by race, with the white race perceived as healthier, survey-based categorical data. When assessing racism, what approaches or indices can we use, quantitative speaking, to determine racism's influence as a determinant of health? Are we there yet to establish cause and effect relationships, as happens with the omics field? From an anonymous attendee, Dr. Jones, how can a physician of color direct a conversation around racism or help to dismantle racism with their colleagues, patients, and those within a community a physician serves? From student Dr. Jacoda, is it our responsibility as physicians to have conversations about racism with our patients, if and when it becomes relevant? How do we handle interactions with patients that may have shown signs of racist behavior? A couple of others that came in also anonymously. How has racism and health inequity changed since you were in medical school? There was a question about, let's see. What classes, degrees, certificates, and/or trainings would you encourage us to pursue in order to better prepare to confront racism in our future workplaces? The premise of a single-payer healthcare system is the ability to improve access to care for everyone. Do you believe that a single-payer healthcare system can combat racism seen in medicine? There was a question also about white privilege, and unfortunately I had it in front of me. How would you explain white privilege to a white person who does not feel privileged in any sense? Those are most of the questions that are either pre-submitted or appeared in the chat, and I apologize to anyone if I've missed your question, but I do think we have a number of them that were presented, and they do tend to start to repeat just a little. Dr. Jones, do you have any closing comments in response to this session?
So I have to say that I have loved hearing your questions. There's the thing about time constraints and feeling human, or how do we discuss racism with people? I think those are very interesting questions. And if you view people as human, then you will treat them as human, even in time constraints. But what we might need to do is not just you as the individual, but push against those time constraints and say that it's adversely impacting your care, your ability to deliver quality care. The questions about the white man who's privileged and other people, and I just came off of from you all, before you all, I was on this amazing kind of panel discussion on allyship. And so what I'm going to do is recommend that you look for the National Center for Civil and Human Rights. They just at 1 o'clock, at 12 o'clock Eastern today, they must have a series on allyship, but the one that was 12 o'clock Eastern on October 30th, it may not be posted yet, but this was amazing. And you guys might need to include that in your curriculum. I was one of 4 people and we were just talking to each other. It was mind blowing. Health perception bias by race. I would refer you to a paper that colleagues and I published in Ethnicity and Disease in 2008, and the title is Using Socially Assigned Race to Probe White Advantages in Health Status. So it's Jones CP et al. 2008, Ethnicity and Disease, where we looked at this variable socially assigned race, which is the question is, how do other people usually classify you in this country? Would you say white, Black or African American, Hispanic or Latino, Native Hawaiian or the Pacific Islander, all these things. So what you'll notice is it's not how you self-identify. And you'll also notice that we didn't make an artificial distinction between so-called race and so-called ethnicity. We put them all in the same list. So the Hispanic or Latino is in the same list. It's an amazing thing that shows that even for people who self-identify with non-white groups, if they are usually classified by others as white, they have much higher levels of self-rated health, and the levels are indistinguishable from people who self-identify as white and are usually classified by others as white. So if I had the title that I wanted for that talk, then it would have been The Health Benefits of Living White. So that's a little bit of an answer there. How has racism and stuff changed since I've been in medical school? Well, it's all different flavors of racism, but we haven't dismantled racism in this system. I'm pleased that more people are recognizing it now after the public lynching of Mr. George Floyd, and then many others. But as I say, my intent, all of a sudden, I've been doing this work for 25 years, and all of a sudden people wanted to hear from me like actively, and CNN and other in NPR and Scientific American. I had all of these interviews, first with COVID-19 and then after the murder on Memorial Day. And I am pleased at that. I am fearful that our level of attention might wane because racism denial is so seductive. So I intend to continue. So I don't think things have changed, but maybe they could. I don't think things have changed yet, but we're in a moment. And maybe they could. And so I will not let this in my work fade. I will continue to push a national campaign against racism. And I have 4 policy things. And this will be the last thing I say. I'm sorry that I haven't gotten to all of the questions. I at least wrote them down. But the 4 policy planks of my national campaign against racism are: first, reparations to descendants of Africans enslaved in the United States, as well as in that reparations piece, like full honoring of treaties, negotiated with indigenous Native, North Americans, so our Native American population. So because that's the foundational racism in our nation, the taking of the land and the taking of our labor and our humanity. So reparations. The second is decarceration, which some people like Angela Davis for centuries has been talking about, abolition of prisons. So I have to read her work more, but certainly the decarceration that we should be modeling even during COVID-19. The third is massive investment in communities of color. Some people have described, actually Dr. David Ansel from Rush Medical Center, which is one of the healthcare anchor network hospitals, described it as a Marshall Plan. But massive investment in communities of color around housing and green space and schools and environmental cleanup, and investing in banks and investing in businesses, right? And the fourth is massive investment around families and young children, early education, all of those things. And we will know when all of these things have worked, we will know that because the term disadvantaged child will have no meaning. We will not even be able to imagine as a society a child either being born into disadvantage or finding themselves in disadvantage. So it's not a 5-year plan, and it's not even a 20-year plan. And very early on, I thought that I was going to equip the nation for a national conversation on racism and then pass that baton on to my children's generation, which would be a national campaign against racism. And they pass that baton on to their children, where it would be dismantling the system and putting in its place a system in which all people could know and develop to their full potentials. I think that the timeline has been shortened a little bit, but I'm not, I understand also the seriousness of the opposition, the people who don't want to see all of us as fully human and all of that. And many of them are well placed right now. So I'm not naive about the opposition. But I do think that this is our cause. And so you guys have been listening so patiently. And so I encourage this institution, you guys, to become part of the solution. Join the National Campaign Against Racism, become actively anti-racist. Look up, there's one last thing for the librarian. In 2018, I have a paper also in Ethnicity and Disease where I outline an 8-part anti-racism collaborative, an anti-racism collaborative with 8 collective action teams. And I would love to share more information about that with you guys as well, once you read it, if you wanted to reach back out to me. So that's that.
Dr. Jones, we feel so fortunate that over a year ago, Dean McKernan recommended you as a nominee for this lectureship. And after that time, our students, before they even arrived on campus, sent us a letter calling us to take a stand. And we're so proud of them for doing that. And then for you to call and accept this invitation, everything fell in place beautifully. I think that if you were here today, we'd all stand. This would be a standing ovation. But even if the panelists were to stand, we'd all go off screen. So I'll just have the panelists unmute themselves, join me in thanking you, congratulating you, and showing appreciation for your work.
Thank you very much.
Thank you for coming.
Thank
Thank you so much, Dr. Jones.
Thank you, Dr. Jones.
Really
Thank you,
appreciate it.
guys. Thank you.
Thank you all for joining us. Have a lovely afternoon.
Bye-bye.